Hello, hello. Welcome to this chat with Professor Kathy Rowan from London. I will run the interview together with Professor Fabio Taccone.
Hello, thanks a lot. And of course, I thank Kathy Rowan to be there with us and discuss about different topics.
So, Kathy, perhaps you could start by introducing yourself in a few words, please.
My pleasure. Hello, everybody. I'm Professor Kathy Rowan. I'm founder and director of the Intensive Care National Audit and Research Centre, based in London, but working predominantly across the UK and internationally. And I'm also an honorary professor at the London School of Hygiene and Tropical Medicine. And it's a pleasure to be here.
Very good, thank you. Well, you know, we have all been impressed by the work done in the UK about COVID and the way people could enroll patients in clinical trials. And actually last week we had our first chat with Professor Tony Golden, who spoke about recent trials and the REMAP-CAP platform. And so we thought, Kathy, it would be appropriate to invite you to speak a little bit about the data that you could generate and that could help us to better treat these patients. So we are listening to you, Kathy.
Very happy to talk about it. And I suppose one of the exciting things about the UK is the investment in our clinical research network across hospitals. And I think, you know, we have been involved at ICNARC, both in looking at the epidemiology and outcomes of COVID-19. We have an amazing mature network of critical care data collectors in critical care units, which we were able to accelerate and provide early data on the epidemiology and outcomes of COVID-19. And at the same time, we were the clinical trials unit for the UK part of REMAP-CAP, the adaptive global platform trial that was evaluating domains and interventions for patients, trying to understand as quickly as we possibly could with the epidemiology and outcomes all about this dreadful disease, this new disease that our clinical colleagues were facing. And at the same time, alongside that, starting to evaluate possible interventions that might aid recovery. And probably the exciting part for us has been doing those two activities side by side, while also linking with the recovery trial, which is a trial more of hospitalized patients with COVID-19, making sure our data in critical care was linked as widely as possible. So we've tried to use our data maximally. So we've linked the data on critical care patients to genetic data. You'll be aware of Professor Kenny Bailey's paper in Nature that identified particular sort of genes associated with COVID-19. We were able to help with the recruitment and also the description of the patients for that genetic work. And we've also linked with other scientists, basic scientists, trying to understand the mechanisms of the disease, and then also through to linking with primary care data so we could understand the trajectory from the community of COVID-19 into the hospital and into the intensive care unit, so we could understand not just the risk factors for intensive care admission or the epidemiology within intensive care, but maybe also the risk factors for hospitalization with COVID-19. What we've tried to do using, I think we're incredibly lucky in the UK to have very well-resourced networks from our National Institute of Health Research, Clinical Research Network for research, and our mature audit network to be able to generate these data and learn as quickly as possible.
Yep. Can you remind us how many hospitals are involved and if it's mandatory to participate or are people paid for this? How does it work? And then Fabio will have some other questions.
Yeah, our national clinical audit is not mandated, but we've grown it over the years such that it's become, I hope, seen as valuable. And I think I always never wanted to set up a club that you were made to be a part of. I'd rather set up a club that you want to join. And that's how we did it. And it's subscription based. So it's the community coming together to, we're an independent, not-for-profit scientific organization. So we run it on a cost recovery basis. We cover England, Wales and Northern Ireland. You'll know the United Kingdom also has Scotland in it, but Scotland have a government-run equivalent to our activities in England, Wales and Northern Ireland.
Okay, Fabio?
Yes, I'm of course very impressed for the work you have done in UK, and you mentioned of course the ICNAC database. We have been participating also including patients in the ISICEM database, which has also been initiated in UK, mainly UK, but not only in UK. So my question is just on a more general base, is this a unique situation which you were able to create in UK? Or can you mention maybe other countries or organizations that are able to provide a huge amount of data in terms of epidemiology in general for hospitalized patients and more in particular for critical care patients?
So I think there's a very strong tradition in critical care. It's very data generating, you know, critical care doctors use data to understand how to treat their patients. And there are a number of organizations and sort of databases that accumulate critical care data internationally. And I don't think they take one form. I think people have established them in many, many different ways. And I think because COVID-19 has impacted critical care so in such a hard way, you know, caused such burden on our critical care colleagues, I think there's been a huge coming together of critical care data. I think the timing, you know, the pace at which we're working and learning means it's not been so easy to bring international data harmonized together to understand, and that probably will be done after the event and to understand exactly what went on. But I've certainly participated in a number of national and international, obviously virtual, Zoom and Teams are my thing these days, sort of seminar and discussions where we've shared critical care data across nations, which I think has been invaluable.
Yeah, absolutely. What have you found from this data analysis before we go into clinical trials? But first, what did the observation tell you?
Really good question. So we felt it was really important to inform our clinical colleagues of the wider experience as they began to see their patients early. So we started doing these weekly reports from the middle of March, you know, with maybe 100 patients in them. Now we've wave one, which we considered over at the end of August, there were 11,000 patients, and we're now escalating up in our second wave to close to 11,000 patients. So this is a lot of people who've been critically ill, and it comes with a in-hospital 28-day mortality rate of about 40%. It was higher initially, but fell in the first couple of months, probably due to learning and understanding of the disease. It's a disease that is predisposed to men over women. So more men seem predisposed to get critically ill with COVID-19. It's a big risk factor to be older. I approach 60 and I'm getting into the danger zone. But certainly for the 70 and 80-year-olds, it seems to be predisposed with those with a higher body mass index, sort of 30 and over. And then also there's been a predisposition for people from more deprived areas, living in more deprived areas, and for some of the non-white ethnic groups. And I actually think we've played a role in the whole public health debate, because I think COVID-19, I can speak for the UK, has exposed some of our health and income inequalities around who are our key workers, who are the people who have to carry on working when the rest of us maybe are able to be furloughed, who are the people living in crowded housing where transmission of infections generally is higher, who are the people who have lower access to care and therefore as a result of that more comorbidities. So it's been interesting as somebody who was trained, sort of I came up through epidemiology and public health, actually to be back in that debate around, you know, it is a disease that is exposed.
What about the ICU patients and the trend over time? Is there any difference in the way we manage these patients respiratory-wise or organ support-wise?
Yes, John Louis. So obviously, any data, quantitative data, they don't get all the detail out. But there's no two ways about it that in the early days, more patients were being intubated and put on invasive ventilation, and earlier. So in the first 24 hours of the ICU stay, there has definitely, there's no two ways about it. A patient is intubating and being on a ventilator, absolutely, that is an important thing to do. But you get the sense there may have been a gray zone. Some patients who previously were being intubated now are not intubated, or they have longer on non-invasive ventilation. My sense from my clinical colleagues was some of the low saturations they were seeing were quite scary, and therefore their practice sort of moved towards what they would do normally in that situation. And actually what they've sort of understood is actually some of these patients can be managed okay with non-invasive methods. I think the issue becomes that maybe the pendulum swung to maybe perhaps overuse or too much invasive ventilation, not to swing to total reliance on non-invasive ventilation. And I think that's the debate at the moment that we can mainly see. It's very, very complex. These patients, when you think of sort of their PF ratios, they're in the very severe category in terms of sort of ARDS. We did see high mortality right at the beginning, over 50%. It's dropped, which is good news. And interestingly, when you plot that against, say, something like the dexamethasone result from the recovery trial, we saw the improvement in mortality ahead of that result. So it was happening ahead of the dexamethasone result. I'm sure the dexamethasone and the steroid advice from the randomized controlled trials has been beneficial to patients, but it's a complex interplay of all, as we know in critical care. It's never one intervention. It's a complex interplay of many interventions and many sort of therapies.
I have maybe two questions, Kathy. The first one is that you mentioned a lot of data about patients, and of course that's really, of course, relevant. But as you have the data about the different hospitals and organizations, I was wondering whether this kind of databases can help us to understand the role of ICU overflow or overload, which means when you create too many new ICU beds. I know that the patient-nurse ratio in the UK is different, in other European countries, difficult to translate, but we have this data in Belgium that suggests that maybe when there's too much work in the ICU, this impacts the outcome of these critically ill patients. Can you
So historically, we've looked at what you're calling is strain on the ICU. It's sort of where we're, and funnily enough, there is a theory that sort of when we're under a little strain, that's actually quite good for us. We function really, really well. And it's only when we're overwhelmed that we begin to kind of, to actually sort of not perform so well. So initially our sort of work on trying to understand that was, first of all, to actually see if there were differences across units. So the first thing we did was apply our usual risk prediction models, and they didn't fit COVID-19 patients. They underpredicted mortality. So then we moved on to building new risk prediction models for COVID-19. Because if you're going to look at something like strain, you've got to be able to risk adjust for the patient characteristics that I've been talking about. So then we've done that, and we've shown sort of variation across units. This work we've done very much with our units to try and understand best practice as well. We had some units who appeared to achieve better outcomes for COVID-19 patients in the first couple of months, and trying to understand what were they doing, how were they managing patients. Now we're beginning to move on to look at exactly what you're talking about. And there are parallel data that have been collected by our health service executive around sort of the staffing levels that units have been able to achieve and maintain across the different sort of surge of the epidemic waves in the UK. Early data suggests that there could be some relationship. It's not sophisticated analysis at this point, but it is definitely something. I have a meeting in January very much to address this particular issue. It's very much at the forefront The other thing that we've been looking at is usually in critical care, we don't like to transfer patients around critical care units, for non-clinical reasons. To alleviate burden, we've been doing that a lot more during the COVID-19 epidemic in the UK. And that again is something we're looking at to see whether that was actually detrimental to those patients who were transferred between units. Obviously, being transferred for something like ECMO for more specialist care is an obvious thing to be doing. But these ones where you're just dealing with capacity.
Yeah. Can I also add my second question, if I can? So you mentioned already that because also of the introduction of dexamethasone, and maybe also because we know much better the disease, we have this reduction of mortality. And I was wondering, we of course are interested in intervention, but we could also be interested to know which is the profile of the patients who do not respond to therapy. We have faced patients on dexamethasone, they receive dexamethasone, and we see they do not improve. Can epidemiology help us to maybe predict the trajectory of the patient, even when they receive the standard of care, the best standard of care?
Absolutely. So yes, there are techniques to do that, if that makes sense. I think at the moment, it's about they require data from many different sources rather than one source. And so it's not really ever that the scientific method is the thing that holds us back. It's actually the pooling of the various data sources to have the sufficient information that you could, but one of the things we want to look at is, if a patient was of a particular characteristic in that first wave in the United Kingdom and was invasively ventilated, but in the second wave, someone who looks like them was managed on non-invasive ventilation, were those outcomes achieved similar sort of type thing? So there's lots of questions, I think, around how we manage patients, how we decide that somebody's not a responder. And you're aware, I'm sure, that even outside COVID-19, we're starting to try and see whether we can categorize patients going into trials as patients who would be likely responders, maybe using various biomarkers or other things, or even having a sort of staged randomization where you only continue if the patient in the first randomization is looking like a responder. So I think, in a pandemic situation, I think it's been amazing to get something as sophisticated as our adaptive global platform trial up and running. I mean, it's been phenomenal in critical care. And we've been recruiting about 25% of patients with COVID-19 into the trial, which is a very, very high recruitment rate for a trial.
Yeah, very good.
But I think there is a problem of sort of doing some more of these things while in a pandemic. I haven't stopped. I don't know about you guys, and you're clinical, so I don't have that burden. But I'm running on empty. It's been a very, very hard year. Trying to do the best we can to inform care and outcomes.
Yeah, we have not been so good at the international level in developing good strategies, and even in France with discovery, it was not so good. But can you tell us a little bit at the end about clinical trials, and perhaps could you, from your large databases, find some interventions that may perhaps be effective? Of course, tocilizumab comes to mind, but there are some other strategies that perhaps we could consider.
So I think trials are the only way, in a non-confounded way, that you can evaluate whether a technology is clinically effective. And certainly in the UK, cost effectiveness is also something that we think about, but perhaps not so much in the pandemic or epidemic times. I think in terms of using clinical databases to identify new therapies, it's probably more through data linkage, if that makes sense, to these other data sets. So I think it's really quite exciting to understand the genetics of the disease, and then to understand which pathways are most likely to be susceptible to what types of drugs. And then you can start to predict from a kind of a suite of possible interventions or drugs or therapies you want to intervene with, which ones have a greater likelihood of working. So I think we can do a much better job. I think we've learned a lot about prioritizing interventions for COVID-19. I think one of the things that's been interesting for us in critical care is we rarely deal with a disease that's a little more homogeneous. COVID-19 is a little more homogeneous. So, you know, we talk about our issues with sepsis. Sepsis is a really heterogeneous sort of syndrome. So here we've got people with COVID-19 who some people will say is a viral sepsis, and they're homogeneous. So we have a much better hope of, if you like, identifying for them what interventions, what therapies might work. And I am, you know, the idea that in the course of a really short period of time, we've already identified some things that will help patients and improve outcomes is to be applauded.
We need to go more into the biomarker field. Do you think we should have more biomarkers of all kinds?
So I think we should be sensible about biomarkers. I think we all, you know, we all get excited about things and we all rush off and start looking at them. And I believe that science has fashion in it, like other things have fashion in it. So one day we're all looking at one particular biomarker and then we're all rushing off to the next one, who's the new kid on the block. That doesn't mean that I don't think they are important or have a role to play. I just think we should do good, sensible science to understand. And a bit like, you know, Jean-Louis, you and I have had discussions about when you do or do not rush into evaluation in a clinical trial. And we can all identify trials where we've rushed in too early. I think it's the same notion. It's about doing the important groundwork to understand before we then, but do they have a role? I would be surprised if they don't have a role in our understanding.
Okay, Fabio, last question, because we'll have to end up soon.
I think the very quick question is just to tell us how you could manage the quality of data when people had to give you all this information in so rush time. But of course, that's the basic of the quality of the results you get from these big databases.
Very good question. So I would argue, so no data are perfect. That's the first thing I'll say. So I'm not sitting on any perfect data anywhere. So what you're trying to do is get your data as accurate as possible, complete, valid, and reliable. I think we learned from the H1N1 pandemic where we tried to add additional data onto our system and people were unfamiliar with it. And we actually pretty much, you know, messed up the whole lot. This time we stayed with our standard data set that they've been collecting year on year. People are comfortable with the rules and definitions. Were the data perfect in those early reports? No, but I think they were sufficiently robust to start to inform our clinical colleagues. But because we included, as we were validating as we went along, we were kind of, if you like, improving not only the content of the report by trying to put the things in it that the clinicians wanted to see. We'd watch Twitter all week and add things for the clinicians as the questions arose. We were also obviously back improving the data, you know, slowly getting it higher and higher quality. And I think that's just you know, you were never going to have perfect data at the beginning of an epidemic, but maybe at the beginning of an epidemic, any data that gives you some sort of view of the experience. And certainly we caveat everything we present. We always say, you know, these people are missing, this is not here, you should understand that differently.
Thanks.
Kathy, thank you very much. Fabio and I, we thank you so much. It was very useful. Enjoy the end of the year. It's almost over, so enjoy it. And we will see you in 2021 in a very good shape.
I look forward to it. Thank you so much.
Thank you.
See you. Bye-bye.